Good morning, good afternoon, good evening, ladies and gentlemen. And thank you so much for joining us on this webinar, the launch of our World Alzheimer's Report 2021, Journey Through the Diagnosis of Dementia. The report was prepared by McGill University. I am Paola Barbarino. I am the CEO of Alzheimer's Disease International. About ADI now, we were established in 1984. We are the umbrella organization of Alzheimer and Dementia Association around the world. We have 105 full members association and federation. We only have one per country. And in addition, we have about 20 countries which are in development. We represent you all at the WHO, at the UN, at OECD, and other global and regional bodies. And we are the promoter of World Alzheimer's Month and the publisher, as you know now, of the World Alzheimer's Report and others. Our vision is prevention, care, and inclusion today, whilst we are waiting for a cure for tomorrow. Now, a few words of housekeeping before we get into the body of things. You will see that in the chat line, there are instructions on how to join our artificial intelligence-led translation. It's not a translation, it's subtitling in 21 languages. If you follow the link in the chat, you will be able to access 21 different languages. If during the webinar you want to introduce yourself, please do so in the chat. But please put your questions to us in the Q&A box so that we can then answer them at the end of the webinar. The slide you're seeing now is the slide that announces our next global conference, our 35th, which is going to take place in London, both online and in person, we hope, on the 8th to 10th of June 2022. Now, this World Alzheimer's Month, our tagline, No Dementia, No Alzheimer, is very popular indeed. Please do interact with our social media accounts to spread the voice of World Alzheimer's Month. You can see them here. Please make a note and continue. I can tell you now that as we stand, we have broken our record of last year by far. Last year, we had about 20 million people interacting with our Awareness Day. Right now, we have 31 million. So we're breaking the record big time. Please continue to do that, because the more of us we end up with, the more we can go to governments all over the world and demand change, because there are millions of people that this is affecting. Now, I also would like to give a thank to our sponsor, in particular to Biogen, to Roche, and to Lilly, for having been such a long-standing supporter of World Alzheimer's Month. And I would like also to remind you that we are a charity, and if you would like to donate, that will help us get where we have to go faster. And I would like to thank all of you, many, 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 that during the last year have helped us financially to do even more. Thank you very much. Now, let me introduce our speakers for today. We have Professor Serge Gauthier, the director of the McGill University Research Centre for Studies in Aging, Professor Anders Wimo, who is also Professor Emeritus at Karolinska Institutet, Roger Marple, who is a person living with dementia in Canada, Professor Pedro Rosa-Neto, director of the McGill University Research Centre for Studies in Aging, and Professor José A. Morais, Director and Academic Leader of the McGill Dementia Education Programme. Professor Suvarna Alladi will join us from India, from the National Indian Mental Neuroscience Institute. Dr. Rufus Akinyemi, who is the Deputy Director, Center for Genomic and Precision Medicine at the College of Medicine in Nigeria, and Claire Webster, the founder and ambassador of the McGill Dementia Education Programme and founder and president of Caregiver Crosswalk. Thanks to all of you who are joining me for this very important webinar today. Now, I'm going to get into the body of the report and its headline announcement. So, every 3 seconds, someone in the world develops dementia. The total estimated annual worldwide cost of dementia is over 1.3 trillion in US dollars, and the figure is forecast to rise to 2.8 trillion by 2030. To the right, you can see the estimated growth in number of people with dementia. 55 million in 2019, 78 in 2030, 135 are predicted in 2050. As you can see, it's a very, very steep rise. So dementia is not going to go away, and we better do something about it. Now, the report today actually addresses the 4th area of the WHO Global Action Plan on Dementia, which, as you know, Alzheimer's Disease International advocated for, and now we are trying to support and to make sure that we bring every government that has signed up to it to task to make it happen. The WHO target is that in at least 50% of countries, as a minimum, 50% of the estimated number of people with dementia should be diagnosed by 2025. But this is not what is happening. And so the report today is here to help us clarify some of those statistics a little bit further. Now, if I can have the next slide, please. So this year we focused on 2 things. The campaign is about knowing dementia and knowing Alzheimer's, and is about the power of knowledge. We need to increase awareness. During the campaign, we are shining a light on the warning signs of dementia. But receiving a diagnosis of dementia is often a very difficult process. And the stigmas around the dementia means that many avoid seeking a diagnosis until it's very, very late. We wanted to look at the geopolitical, social factors that really undermine so far the search for diagnosis. We wanted really to understand what is the government should be doing, and intersected that with the experience of people living with dementia, of carers, and of people from all over the world, because you know that there are a lot of disparities and inequality. And we have found a lot of very interesting things, which will be presented by my co-presenter. Next slide, please. During World Alzheimer's Month, we have also doing a lot of awareness raising. You can see here a little abstract of many, many things that we are talking about this World Alzheimer's Month. Next one, please. And now we get to the body of the report. McGill has been delivering this report, and is a global perspective on the current dementia diagnosis practices, the barriers, what are the facilitators, and the emerging and imminent future impact of diagnostic breakthroughs, of which you will have heard about. And in addition to that, we present you with a strong set of recommendations, in particular for governments. I know that there are people from governments listening to what we are talking about today. Next slide, please. Okay, so now we get to some of the top line funding. So globally, following this report, we estimate that 75% of people with dementia are not diagnosed. And this is pretty much 41 million people. So if there are 55 million people with dementia in the world, 41 million do not even get diagnosed, with the consequence of confusion, ignorance, fear, stigma that we all know about, and of which our speaker will speak further. The rates of underdiagnosis are inversely related to the income of countries. So we go from about 60% in higher income countries to about 90% in lower income countries. And following a quite comprehensive survey, 55% of people say that they were given inadequate information at diagnosis. And this is a major problem of signposting from clinicians. So a lot of primary care doctors give you a diagnosis and leave you like that to work things out for yourself. And this can endanger all kinds of complexities, from fear, from panic, from sometimes catastrophic consequences. But interestingly, 98% of Alzheimer's and Dementia Associations around the world are offering services, information post-diagnostic support. So then that begs the question, why aren't primary care physicians signposting these resources? Because they are there. And in any case, shouldn't governments take it into their healthcare system practices on their website to actually signpost people to the information? One of the reasons we did this report is the convergence of a number of important factors this year. New therapeutic breakthrough, the possibility of a new diagnostic system, the fact that population aging is continuing, there is now a link between COVID-19 and the possible risk of developing cognitive deterioration. So this is a kind of perfect storm, and we wonder what are the governments doing to give people the real information that they need in order to make their life better, because let's remember, people can live well with dementia for a very long time in their home, if only they are told how. So next slide, please. Continuing with the top line finding, 47% of people living with dementia and carers identified the lack of trained clinicians as a barrier to diagnosis. 46% of people living with dementia and carers identified fear of diagnosis and stigma as a barrier. 33% of clinicians also believe that nothing can be done about dementia, so why bother? So this is a massive statement of stigma, of not believing that people actually have a right to know about diagnosis, and they have a right to know what's going to happen so that they can do something for themselves, as we will hear from some testimony later. Next slide, please. So, some selective recommendation: healthcare system globally should introduce annual brain health checkups for the over 50, facilitated by a revolution in biomarker science, with the opportunity to promote risk reduction strategies. Governments globally must urgently start to measure and record diagnosis more accurately. Accurate measurement of diagnosis rate is key to treatment, to care, to support, to healthcare system preparedness, and to challenging stigma. And our report next year, the 2022, is going to focus on post-diagnostic support. So we will be continuing this discourse for this whole year, because measurement of diagnosis is absolutely critical. And governments must prepare for a tsunami of demand for healthcare services as a result of global aging population, improved diagnostics, including biomarkers and emerging pharmacological treatments. Next slide, please. The governments globally must recognize the right to a timely clinical diagnosis and put in place the capacity to deliver this to enable better planning, treatment, care, and support, as recommended by the Global Dementia Action Plan of the WHO. We also need to build on the innovative, often technology-based approaches, including telemedicine, which have been developed during COVID-19 pandemic, and research how this can supplement, but not replace, future cognitive assessment, while acknowledging the benefits for remote or rural communities that often don't have anything, or for those unable to travel safely. Next slide, please. The full list can be found in the report, which is very long. We appreciate it, but we made it very easy for you to read, providing executive summaries at the beginning and of each chapter and at the end. Next slide, please. And now it is my pleasure to hand over to the lead person behind the report, Professor Serge Gauthier, Professor Emeritus in Neurology and Psychiatry, Academic Lead, Dementia Education Programme, and the omniscient person that has been guiding my thinking around science for my 4 years at ADI, from McGill University, Canada. Serge, the floor is yours.
Merci, Paola. Bonjour tout le monde. Hello, everyone. Thank you for this opportunity to share what we did over the past 6 months and what we hope to do in the next 12 months. My task is to introduce the report in a more practical way when you start reading it, what to expect and how it was put together. So here you have a description of how it was put together, expert essays. This involves 113 invited authors and co-authors who wrote 52 short essays. The 3 surveys are a main part because it takes into account information from clinicians, people living with dementia and their carers, and the Alzheimer associations. I will get into more specifics of the survey contents. And testimonies are very important. These are case studies from people living with dementia. 11 were selected and are in the report. Next slide. The report is built into 6 parts, as you can read here, from the initial clinical assessment, the laboratory workup, then some personal testimonies from people who've lived the experience of diagnosis and being told about you have dementia, the disclosure, and what happened afterwards, right afterwards. We get into what goes in the clinician's mind when you say you have dementia due to Alzheimer or due to another cause of dementia. We also get in part 5 into particular circumstances that are very important for people around the world because it gets into rural and how do you make a diagnosis when you're far away from specialty clinics, etc. And the last section, part 6, is the future of the diagnosis of dementia. The purpose of the report is really to reach out to clinicians, to people who are going through the diagnostic process, people who've just been through it, their families, and the Alzheimer associations, and people in governments, decision makers. Now I'll get into the more specifics of the survey data. There were, as you can read, 1,111 clinicians of different disciplines, including family medicine, from 108 countries. The people with dementia and carers also are represented from 83 countries. And 101 of the 107 Alzheimer associations gave information. So we're very proud of the contribution from all these people into the report. Next slide. Here's some examples of highlights from the clinician survey. Nearly everyone agreed that cognitive assessments, memory tests, in other words, and more sophisticated tests when required, are essential for the diagnosis of dementia and to track change over time. The most commonly used screening tests, no surprise, are the mini mental state examination and the Montreal Cognitive Assessment. But we got into what about people who have lower education, different culture, different languages, and we have a discussion about that. And we give an example out of Singapore of a visual cognitive assessment test, and we give the details of the test in the report so people can actually study that as an example of culturally adaptable cognitive testing. And we get into what happened during the COVID pandemic from a clinician perspective. And one positive, if you could use that term, outcome of the pandemic is that clinicians have quickly used telemedicine into their practice. And there was one way to reach persons who were known to have dementia and have a good follow-up. Next, please. Next slide, please. Okay. This is some pictograms to illustrate some highlights from the report. On the left, you see that 90% of clinicians identified additional delays for the first-time visit due to COVID. For follow-ups, telemedicine worked fine, but for the first assessment in depth, you really need a person-to-person 1 hour interview, and that's been delayed. So we think there's at least a 1-year backlog now for the first visit for purpose of diagnosing dementia. Only 35% of people living with dementia said they had in-person access to a clinician during the pandemic. The caveat is that if you have a stable course of the dementia, whatever etiology, during the 1 year, year and a half of the pandemic, there were alternative means to contact clinicians, including telephone, Zoom, etc. In the middle is a glimpse at what are the barriers for primary care physicians and even specialists to do a full assessment in someone with symptoms suggestive of dementia. It's really time. In many countries, the care system is such that you have to see so many patients per hour, and you need more than 10 minutes to do a full assessment in someone with symptoms suggestive of dementia. And on the right, you see that 75% of clinicians ranked the increasing number of people seeking a diagnosis as a major challenge for the future. Indeed, there's going to be, as Paola was saying, a perfect storm. I think the next slide will illustrate that tsunami, if I'm not mistaken. The next slide. Yes, indeed. So this illustration of a tsunami means that there are more people aging, more people are interested in an assessment of their memory, especially if it's declining and interfering a bit with their daily life. There's going to be new blood tests that Dr. Rosa-Neto will get into that will make the diagnosis a little easier once you have symptoms. And there will be new treatments. So a combination of factors is such that there will be more demand on the healthcare systems for diagnosing dementia. Next slide. Selected recommendations among many that you can read about. The healthcare systems must make cultural appropriate, properly translated and validated cognitive assessment tools. So as populations now are more educated, they may have access online to certain cognitive tests, so there may be a practice effect. We need to have neuropsychology and other healthcare professionals put together their mind about how to develop more sensitive testing. There's a call for standardized online information to mitigate against dangerous misinformation. And finally, one word that we really want to emphasize, and we will build on that for next year report, is training. Training in medical schools, nursing schools, all allied health professionals. Training should include information about cognitive decline with age, dementia, and what do you do after the diagnosis of dementia. So this will be something we will build on in the ongoing year. I think that's my last one. Thank you. Merci.
Thank you very much, Serge. We continue to receive a lot of messages. There are well over 700 people online. We haven't counted you all already, but it's a lot of you following. Thank you so much. It is now my pleasure to introduce you to Professor Anders Wimo, who is Professor Emeritus of the Department of Neurobiology, Care Sciences and Society at Karolinska Institutet in Stockholm. And Anders' research areas, as many of us know, are geriatric health, economy, and epidemiology, and he has also co-authored some of our World Alzheimer's Report in the past. Anders, the floor is yours.
Thank you. And alongside my work as a researcher, I've also been a practicing family physician in the rural area in northern Sweden for more than 30 years. So with a focus of elderly people and elderly care, and also about dementia, work in primary care. As Paola said, today we have about 55 million people living with dementia worldwide. And of those, more than 60%, they live in low and middle income countries. And of the global cost, about $1.3 trillion, about 50% of these costs are because of unpaid informal care. And also about, in contrast to the prevalence distribution, about almost 75% of the costs, they occur in the high income countries. Next slide, please. Now, how is the situation in primary care for diagnostics and so on? Well, in the ideal case, the family physician is a specialist in family medicine. He's been working in this area for 10 years, plus 20 years. He's very skilled in dementia. He knows the patients and the families very well. Each visit takes at least 30 minutes, perhaps 60 minutes. The list is maximum 1,000 patients. And close relationships to the families, and we have a local dementia team with GPs, nurses, social workers, etc. And we have a basic dementia diagnostic workup package, which is also remunerated. Well, this is not reality, of course. Reality is most often that we have full waiting rooms. The list is 3,000 rather than 1,000. The commission is very broad. The GP should do everything. Each visit takes perhaps 5 or 10 minutes instead of 1 hour, and the GP is paid per visit, and the skills vary a lot. Some are very competent and some are very bad, and all diagnostic tools are burdening the budget. Next slide, please. And of course, it's not possible, as Serge said, it's not possible to set the diagnosis of dementia or pre-dementia states by a visit about 10 minutes in primary care. Next, please. Now we are having new challenges besides the challenge we also have in primary care today. First, of course, we have the bomb this summer that FDA gave a conditional approval for a disease-modifying treatment, aducanumab, in the US. The next phenomenon is perhaps not a bomb, but prevention is probably possible in dementia, mainly focused on cardiovascular risk factors that's shown in many population-based studies and also by the FINGER trial. But this is already part of the primary care work today. But nevertheless, and consequently, the diagnostic boundary or ribbon will shift from dementia to pre-dementia stages, such as prodromal dementia or mild electrical impairment or other conditions, and also perhaps preclinical stages, that is without symptoms, but changes is ongoing in the brain. And it's also crucial to identify the type of cognitive impairment. It's Alzheimer's disease, is it vascular, and so on. Next slide, please. So, added to the problems in primary care and also in specialist level, we have new problems. One, of course, is the diagnostic capacity. And as the RAND Institute has shown in reports for US and also for Europe, that the diagnostic infrastructure is not prepared at all for a large increase in demand for pre-dementia and early dementia diagnostics. Many people have subjective memory problems, of course, and they want to know, do I have an early Alzheimer's disease that is treatable, and so on. Another concern is about the diagnostic accuracy, because even if we have a very good diagnostic package in primary care with blood-based biomarkers and some cognitive testing and so on, if we have a sensitivity of about 90%, a specificity of 90% of such a diagnostic package, with a prevalence about 10% of the elderly, which is rather reasonable for MCI, for instance, the positive predictive value or the probability to set the correct diagnosis of early AD is about 50%. So the label is very important. We shouldn't say that you have an early AD based on this testing in primary care. We can say that you are at risk. And then, of course, we have to make a referral to a specialist for a very comprehensive diagnostic confirmation, or reject the suspected early AD and so on. So this is crucial. The label is very crucial. But then, of course, we have the really basic questions. If we get disease-modifying treatments available in many countries, who will get it? There will be millions that will ask the question, do I have an early AD and so on? And who, if we confirm a diagnosis of early AD, who will get it? And then also, who will pay for it? Because the suggested price in US, about $56,000 a year, will really have extremely heavy burden, or action more or less an unrealistic burden on any drug budget in any country and so on. So, and further on, what about the global access to diagnostics procedures and also disease-modifying treatments, particularly then in low and middle income countries? So really, we do have a lot of challenges to discuss here later today. Thank you.
Thank you so much, Anders, for this brief but incredibly contentful presentation. Lots of questions are coming in. So without further ado, I'm going to cede the floor to Roger Marple from Canada, who was diagnosed with early onset Alzheimer in 2015. Roger, the floor is yours.
It's a good day. I remembered to unmute myself. I thought I would share how I see things on the receiving end of the diagnosis with a terminal form of dementia. And I noticed in this report that up to 75% of people living with forms of dementia go undiagnosed in society. And I thought I'd open with a story of caution. I understand that there's many reasons why people go undiagnosed, but my comments here go towards people who have access to services for a diagnosis such as this. And I met a woman who told me she was on her way to tell her mother that her sister had passed away. She went on to share that her aunt showed symptoms of dementia, and the family collectively decided not to seek a diagnosis due to their assumption that she had a form of dementia, and being a terminal condition, they didn't feel the need to get a diagnosis. Things came to a head when the woman's symptoms become more pronounced, and they were forced to take her to a doctor. When the doctor heard of their assumption, the doctor said he would do his own evaluation on her. They found out it wasn't dementia at all. Turns out it was a very treatable brain tumor, and sadly, due to waiting to see their doctor, the tumor had advanced to the point that there were no treatment options that were available. The moral of this story is, do not assume you know more than your doctor. That assumption cost this woman her life, and she died before she needed to. There are also many treatable conditions that could be manifesting similar symptoms. You'll never know without a doctor's assessment. I've often heard comments from the assumption that forms of dementia are terminal, and for that reason alone choose not to seek a diagnosis, not seeing any benefit towards this. And I can tell you, nothing could be further from the truth. If I had a nickel for every time my doctor pulled a rabbit out of her hat to help me with this journey, I would be a rich man. It could range from treating underlying health conditions such as sleep or health style choices that directly has benefited my life. People walking this journey and loved ones who live with this condition as much as we do have a choice to make. I'm sorry, I lost my spot. Okay, people walking this journey have two choices to make when we are walking this journey. One is to do nothing and approach this journey from a reactive approach, stumbling your way through this, or you can choose to approach this from a proactive approach, which in return, and trust me when I tell you this, improves the quality of life for all involved. And my last point is directed towards healthcare professionals who give a diagnosis of forms of dementia. When I received my diagnosis, my doctor did not pull any punches on what to expect with my diagnosis. And by the time we were done, I totally understood where I stood with this and what to expect. And I gotta say, I admired his openness and transparency. After all, it is my life. This practice of openness and transparency are values that our healthcare professionals hold dear to their heart. This is the drumbeat they all march to. There are a few steps I would encourage doctors incorporating into their diagnosis process. And pretty well everyone with a form of or with a diagnosis of dementia will go to public media to research their condition. The problem is that we learn about forms of dementia in a reverse chronological order, often learning what dementia looks like in the most challenging stages in this journey. In return, this puts people into a tailspin of despair on how their life will look down the road, not realizing it's possible to live a good quality of life for some time to come. And in many cases, losing sight of that. I call it the sea of despair, and almost everyone receiving this diagnosis will experience this to different degrees. A simple comment like it is possible to live a good quality of life for some time to come, regardless of upcoming challenges, and encouraging us to be all we can be, would plant a positive seed at a very distressing time in our lives. And as we analyze this important discussion, and trust me, we will remember that simple comment. You will not be making any promises you cannot keep. You have just finished telling us in detail the realities of this condition. It's just another plane of thought to consider. The other is making a referral to your local Alzheimer's Society. The reality is we see our doctors out of necessity. On average, we see our doctors towards our condition 2 to 4 times a year, perhaps 15 minutes to half an hour per visit. So what happens the rest of the time? Whether you know it or not, medical community, your Alzheimer's Society takes a huge amount of work off your shoulders with credible, researched information, to steering people to resources, to helping people proactively crossing bridges as they present themselves, and the list goes on. In Canada, they work as a team together in their care for people and families with dementia. And it is wonderful to see this in action. And I encourage other countries to consider this approach. These 2 simple steps I just mentioned, if incorporated into your transparent process, diagnosis process, would only take a moment. And I feel strongly would totally change the trajectory on how people would approach a diagnosis such as this. I thank you for your time.
Thanks a million, Roger. This means the word coming from you. I think to look at this properly, we can only look at it from the point of view of people in the system that feel that they are being summarily looked at, dismissed, sometimes never reviewed, as many people point out in the report. I really do encourage you to read the report. It's a rich tapestry, very complex, and Roger has pretty much touched on all the elements of it. Roger, thanks a million for your testimony. Now it is my pleasure to give the floor to Professor Pedro Rosa-Neto, the director of the McGill University Research Centre for Studies in Aging, and professor at the Department of Neurology, Neurosurgery, and Psychiatry at McGill. Pedro, this is your moment. The floor is yours.
Thank you very much, Paola, for the nice introduction. So the first slide, I'd like to say that dementia is a clinical diagnosis that is caused by underlying brain disease. Research has shown that these diseases processes start many years before the dementia symptoms. Such diseases may affect the circulation, preventing the arrival of nutrients in the brain, or can be a result of abnormal proteins that, instead of being eliminated by the brain, accumulating, reaching toxic levels, or even both processes together. Important, the disease processes typically have a long and silent phase where the disease develops without symptoms. Therefore, one may say that one can prevent dementia by halting the disease process before the emergence of the dementia symptoms. Next slide, please. As Mr. Marple remarked, brain scans and laboratory are important in the investigation. When the healthcare professional makes the diagnosis of dementia, it's very important to rule out the presence of treatable diseases that can cause dementia symptoms. Brain tumors, as he said, is an example of the disease that can be misdiagnosed as a dementia. Next slide, please. Regarding the disease presentation, it's very important to understand that dementia has multiple forms. Even in patients with Alzheimer's disease pathology in the brain, the symptoms might show diverse clinical presentations. While most patients have typical presentations characterized by memory problems, others might have problems related to behavior, language, and the ability to execute acts. This happens because the toxic proteins that cause Alzheimer's disease might deposit in brain regions related to language, behavior, or motor function, rather than memory regions. And here is the example of deposits of amyloid in the brain that causes different symptoms of the same Alzheimer's disease. Next slide, please. We also want to emphasize that Alzheimer's and other types of dementia, they can begin at fairly in young people. It's important to bear in mind that dementia can affect young people, and this situation is called young onset dementia. It can be secondary to Down syndrome, for example, but there are other causes of young onset dementia. This might happen in families, and these manifestations, they deserve to be systematically investigated in order to rule out reversible causes of dementia or genetic conditions that require special care. Next slide, please. This is a very important slide because this highlights the importance of biomarkers. So the scientists have worked very hard during the last 20 years to create tests able to detect underlying causes of dementia in its early stages. These tests bring the hope of early diagnosis and early therapy capable to stop the diseases before causing dementia. Next. One of the most important critiques of the biomarkers in clinical care is the cost and lack of therapies for most of these dementing diseases. Recent developments in biomarker allow brain diseases to be diagnosed using simple blood tests. This brings the hope of early diagnosis and the large-scale clinical trials focusing interventions capable to stop the progression of the disease in very early stages. Thank you so much.
Thank you very much, Pedro, for this very clear and simple explanation of something very complex indeed. It takes a lot of knowledge to be able to do that. Thanks also to all my fellow speakers for keeping to their timing. It is my pleasure to now introduce you to Professor José A. Morais, who is the professor of the Department of Medicine in McGill University and the director of the Division of Geriatric Medicine in the School of Dietetics and Human Nutrition in the Department of Experimental Medicine. Professor Morais has just explained to me that he's originally from the Azores Island, which I don't think we have an Alzheimer's Association in the Azores, which of course are part of Portugal, but we do have it in Portugal. So a big welcome to you, and the floor is yours.
So I will say, hi everyone, bonjour à tous, bon dia. I'm very pleased to be here presenting this part of the work of the report for which we have worked, I would say, intensively for the past few months. My role is to describe the component that pertains to the clinician, the physician, mainly primary physicians. To start with, the diagnosis of dementia is a clinical one based on history, examination, results of CT scan, MRI of the brain, and blood tests. There is not, up to now, a single test that would confirm the diagnosis. So at the early stages, it becomes difficult to ascertain if it is a true dementia versus other causes. And in that situation, it is always better to say the diagnosis is not yet clear so that further assessments are required, and then we can increase the precision of the diagnosis. And for this purpose, follow-up visits are often required to do these assessments and to confirm the diagnosis. And in fact, based on the survey in people living with dementia and carers, it's quite clear that a follow-up takes place in 90% of the cases, and about 40 to 45% off of that is within 6 months. And there is not really a major difference between low income versus high income countries. Next, please. Many challenges presents to the clinician because when seeing a person, especially an older person, there is multiple comorbidities. In fact, older persons present 3 to 5 chronic diseases, and trying to see clear amongst them, it's a task in itself. And during the first encounter, it is also important to rule out treatable causes of dementia, for which there is a need for complementary tests, such as blood tests. And many of these treatable causes comprises depression, thyroid disease, vitamin B12 deficiency, and occasionally a brain tumor, has already been addressed by others. And to do all of this evaluation, physicians have a very limited time available, as being discussed and presented by Dr. Wimo. Next, please. When announcing the diagnosis, we can face a great deal of difficulties coming from different sources. One of them being what we call in medical terminology anosognosia, which is that lack of awareness due to the disease itself, which decreases the self-reflection about what is going on. And many persons suffering from dementia will simply say that they feel fine, they have no problems. We have to deal with that. As well, when mentioning the diagnosis, the way to present it and to whom it should be addressed is in itself requires a lot of skills, because it is more often than not a situation where there is a dyad, meaning that there is a person suffering from dementia as well as a loved one, a carer, that will participate in the treatment of that person. So we should address the diagnosis to both. We have to answer several questions, and before starting in a lot of explanations, it will be important that we listen to the patient and the carer so that we can address their questions, because the questions between the patient and that of the clinician can be very different. And occasionally we are facing with the catastrophic reaction, which is an emotional reaction of being overwhelmed because we have all a perception of dementia that can be wrong, in which we only see the end of the disease, whereas it is a chronic disease that can be in many stages treatable and supported. Next, please. So it is the role of the physician to discuss the management of the condition, both available treatments, non-pharmacological approaches to the treatment. It is important that the patient and the family member understands that the dementia goes through different stages, and there is things one can do, and that information is crucial for empowering the caregiver that supports the person living with dementia. There is also safety issues as well as legal issues, which all of this takes time, and we need a support system already addressed by Dr. Wimo, so that we can approach dementia in a global, comprehensive way. And a lot of resources are available already, and we shouldn't be shy of recommending that the person and the carer see what is available in the associations in our own community. Next, please. And finally, I would say that physicians themselves have their own stigma. 30% of the clinicians in the survey consider that there is nothing one can do to dementia, which is totally false. And we have to overcome these limitations, including our approach that we have to those who have low education, those who are part of the diversity communities. We should be able to address these issues, and more research and the recommendations are needed to this situation for which the report tackles the issue. Next, please. So the clinician must ensure that the person living with dementia and their carers receive the best available care and support. Thank you very much.
Thank you very much, José. It's been important to look at these from the point of view of the primary care clinician. I noticed that there are a lot of questions in the chat box. Please can you put the questions in the Q&A box? We will aim to answer them at the end. So stay on if you want your question answered. Now, can I give the floor to Professor Suvarna Alladi, who comes from the National Institute of Mental Health and Neurosciences in Bangalore, India. Suvarna has been writing the specific essay in the report that deals with the situation in India, which is extremely interesting. Suvarna, the floor is yours.
Thank you, Paula. This World Alzheimer's Report is so crucial for low middle income countries like India, where majority of people with dementia live. And the theme of this year's campaign, No Dementia, No Alzheimer's, is also very apt, since in our country, the journey to diagnosis is fraught with numerous challenges. The next slide, please. It's only 1 in 10 people who even receive a diagnosis of dementia in India. And this is a combination of factors. It's predominantly because there is very little awareness and there are lots of stigmatizing attitudes and also very few dementia specialized professionals and healthcare services. For those who even reach health systems, there is tremendous diversity in health-seeking behaviors, and this is because of differences in geography, in socioeconomic status, and availability of healthcare resources in different areas. And therefore, a person in a rural area might just visit a community health worker, but a person in an urban area, an educated person, might meet a specialist and have an advanced MRI. And so there needs to be more coordinated care between primary healthcare systems and tertiary healthcare systems with some kind of feedback, and that is yet to be developed. Further, the diagnosis of dementia requires that the cognitive tests connect with the person with dementia, with their language, with their culture. And since most of the tests have been developed in the West for English-speaking people, there's a need to have culturally and linguistically valid tests. With the advent of biomarkers for diagnosis, this is making the journey even more complex. And since a lot of expenditure that is borne by the person with dementia and family is out of pocket, it continues to be that much more challenging. The COVID-19 pandemic has further complicated dementia diagnosis. While telemedicine initiatives were started, a lot of difficulties were encountered to conduct cognitive tests via virtual platforms. And therefore, the heterogeneity in health-seeking behaviors is what I would like to emphasize from India, which is a result of diversity in socioeconomic, cultural, and demographic factors. And these actually affect whether a person with dementia receives a diagnosis at all. Can I have the next slide? Some positive steps, in fact, many positive steps. We now have tests in very many different languages in India for people who are low literate, as well as people who are educated. Next slide, please. And the government is moving towards strengthening the primary healthcare system. This is the public health insurance scheme called the Ayushman Bharat that aims to transform existing primary healthcare structure into health and wellness centers with the aim of providing comprehensive primary care. So here we see an opportunity to improve diagnosis for people in the community, in the primary healthcare. And this is a positive step towards universal healthcare, health coverage. And this is going to impact the diagnostic rates in our countries. Next slide, please. And therefore, the key takeaways would be that dementia diagnosis is complex in countries like India, which are very diverse. And so we need to take into account the diversity when we develop strategies to improve diagnosis. It's very crucial that we place persons with dementia and their families at the very center of our efforts. Increasing awareness will be very crucial. And during this World Alzheimer's Month, as we are all experiencing, there's literally an explosion of awareness activities that are happening from various NGOs, the Alzheimer's Association in India, the ARDSI, hospitals, in communities. And I think with this, we look forward to improving diagnostic rates in India. Thank you.
Thank you, Suvarna, for this very fast running presentation, but incredibly complex. And I have to say the level of activities in India during this World Alzheimer's Month has been extremely high. This morning, the Minister of Health tweeted about World Alzheimer's Day. We are a great joy. We all pray for India, one of the most populous nations in the world, to really do a step forward and do something about that national plan, because that would change the lives of so many people. Now, to continue our global panorama of what is happening, because the situation is not good everywhere, but in lower income countries is particularly not good. I'm introducing you to Dr. Rufus Akinyemi, who is the Deputy Director of the Center for Genomic and Precision Medicine at the College of Medicine in Nigeria. Rufus, if you can, the floor is yours. Thank you.
Right. Thank you very much, Paolo, for that brilliant introduction. Thank you very much. I'll be speaking on the challenges of diagnostic dementia in Africa. Next slide, please. Although the African population is pretty young today, nevertheless, the number of the elderly in Africans is on the rise. The absolute number is on the rise. And therefore, the challenges of dementia is also quite increasing on the continent. Next slide. There have been quite a number of studies evaluating the prevalence of dementia in Africa, including recent systematic reviews and meta-analysis. And what we know is that the prevalence of dementia, it's about between 5 and 6% averagely, but it ranges between 3.2% and up to 20%. And there are increasing number of studies as well as efforts such as support organizations and other efforts to improve the science and care of dementia in Africa. There are quite a number of going efforts in Africa. Next slide. Next slide, please. Right. Nevertheless, there are quite a number of challenges that the diagnosis of dementia in Africa faces. Next slide. In Africa, there is suboptimal knowledge of dementia, not just in the community, even among health workers and among students of medicine and other biomedical courses. And this suboptimal knowledge impairs their capacity even to recognize dementias in the clinic. In some surveys among healthcare workers, it's been shown that up to almost about 40% of workers in a particular study were not able to make diagnosis of dementia. And this compounds the problem of the inadequacy of brain health experts, neurologists and psychiatrists in Africa. And this cause for the need for task shifting and task sharing training of non-health workers, non-experts, in order to improve the diagnosis and care of dementia in Africa. Because of poor perception, in much of Africa, dementia is often seen as a part of normal aging. And sometimes it is seen as an expression of witchcraft or as an outcome of curse from the gods. Because of this, dementia is a stigmatizing condition on the continent. And this impairs people's capacity and willingness to present themselves for early care and diagnosis. And people often don't come to the hospital until they develop severe behavioral and psychological symptoms, which further compounds, and in the continent where there is already inadequacy of post-diagnosis care and support, this compounds the challenges of diagnosis and care on the continent. And of course, there is also a challenge of lack of culturally appropriate tools. The most popular neuropsychological tools, such as the MOCA, the MMSC, are not particularly apt for a continent with huge diversity in terms of culture and language. Therefore, there's a need to develop tools that are resistant to the influence of education and culture. And thank goodness, there is already some progress in this direction on the continent. For instance, we do have the community screening instrument for dementia that was developed in continent, and more recently, we have the IDEA tool, which we do plan to validate across the continent. And this hopefully will improve the diagnosis of dementia on the continent. Next slide, please. Next slide. Right. What does the future hold? We have come to a time in Africa where we believe that we need to synergize efforts. Dementia researchers, including medical researchers and care providers, including support organizations, we need to join forces to develop African-led programs to enhance research and care of dementia. And this particularly includes capacity building and educational frameworks that will support the training in the diagnosis of dementia. So the African Dementia Consortium is an initiative that is coming up, and we hope that when it takes off, it's going to spread across the continent, and this will enhance capacity, to make proper diagnosis of dementia and improve the care going forward. Next slide. Thank you very much for your attention.
Thank you very much, Rufus, for this complex presentation, but also full of hope. Africa at the moment is the place in the world with the least amount of Alzheimer association, I would say, with the highest level of denial around the existence of the disease. But I think Rufus' presentation has made it crystal clear. It's a big issue in Africa. We do need to wake up and take action. But it's also good to see some consortia taking place locally. So thank you very much for that. I can see there's a lot of questions coming in. I'm trying to think about how to field them later. But I'm going to give the floor to last but not least, Claire Webster, the founder and ambassador of the Dementia Education Programme at McGill University and founder and president of Caregiver Crosswalk Incorporated. Claire and I met with Serge Gauthier many years ago in Montreal. It was a really insightful meeting, and it's a joy for me to see that Claire has been one of the main authors of the report today, giving us her testimony as a carer. I do recommend to everybody to read her essay. It's profoundly moving. Claire, the floor is yours.
Thank you very much. And this is a very emotional day for me today because my journey has led me here. I'm extremely grateful to ADI and especially McGill University, for whom I had no prior affiliation until 2017, when I really decided to knock on the door of the Dean of the Faculty of Medicine, armed with a mission to change the healthcare system. It was the words of "Good luck, Mrs. Webster," upon the diagnosis of my mother in September of 2006 that led me to be the caregiver crusader that I am today. Other than taking away her driver's license and by me asking, where can I get some information? And the neurologist telling me that there was information available on the web, there was nothing else that was provided. Next slide, please. And I firmly, truly believe that a lack of education about dementia will have a significant impact on the quality of care and safety, not only of the individual, but on their carer as well. This is an illness that has a ripple effect on everyone around them. So as a sandwich generation, as a former sandwich generation carer, as I watched the disease unravel my mother, my children witnessed my own unraveling solely because I was not informed, properly educated, not only about the illness, but about how to navigate the resources around me. So for today, all those people from the government and public health agencies that are listening, one of the biggest challenges that the public faces is how to access those important resources that are out there that could assist us. Next slide, please. But I always thought that the problem was a local issue, a problem in Montreal or a problem in Quebec. But what we realized from the World Report is that the lack of information provided to carers is a global problem. Imagine being diagnosed with cancer or heart disease or any other illness, and the doctor saying to you, good luck, see you in 6 months, leaving the doctor's office without any type of information. Next slide, please. This illness has so many various facets. A lot of people think that dementia equals memory loss, but it isn't. My mother, who was diagnosed in her early 70s, a vibrant, athletic woman, started showing behavioral symptoms. But because, as we mentioned earlier, there are no public awareness campaigns, and people don't know the signs and symptoms, and it's an ever-evolving illness. How could you possibly navigate it? How could anyone know what to do? Next slide, please. So I briefly discuss in chapter 16 my story about what were some of the guiding principles that I learned. And we will discuss more of this in the next year's report. But there are so many things, so many important issues and guidelines that people need to take into account along the journey. And it needs to be done upon the moment of diagnosis and working together. And it will really have an impact on the quality of life of the person and as well as their carers. Next slide, please. Now imagine prior to COVID, there was a problem with families or carers being educated. And now COVID happened. Right, and in addition to what happened that we all heard around the world, long-term care centers and the impact it had on patients with dementia, but here you have all these families who have absolutely no information, education, access to home care support that stopped, respite programs that stopped, and are at home alone thinking, how am I going to properly care for my loved one? So COVID had a significant impact that you will read about in chapter 21. Next slide, please. In next year's report, we are going to really truly be discussing post-diagnostic management and care. We're going to talk about the history of dementia and pharmacological and non-pharmacological approaches. We're going to talk about the impact on young carers, the university students who have to leave school and come back and care for a parent who is diagnosed with early onset. We want to also talk about caregiving customs and challenges among diverse cultures. But the big question that we're going to be looking at is why are carers not being properly informed? What is the curriculum like at some of the major university medical schools around the world? What is not being taught to the students of the future? Because the only way to change the healthcare system is to properly train the medical students and the allied healthcare professionals of the future. We will also be looking at the latest research in preventing cognitive decline. And most importantly, we'll also be looking at the government strategies and policies to support persons living with dementia and care partners. Thank you very much.
Thank you so much, Claire, for this fantastic exposition and also for sharing with us your story, which again, as I said, really should be read by everybody in the report. Such a common issue, as we also found out in the 2019 report on stigma, which if you're interested in stigma, I can see a lot of questions coming in on stigma. I would suggest people read. Now, we have a whole 20 minutes for us to have questions and answer. There's a lot of questions and I'm going to try and steer us through this discussion. Before I do that, I would like to profoundly thank the ADI team who has been behind this report, and in particular, Chris Lynch and Karen Watchman, who have been the driving forces at ADI behind this report arriving on our desk on time and with such richness of content and complexity of texture. Many of you are asking how to get hold of the report, of the slides of this presentation. Presentation is going to be uploaded on YouTube tomorrow. The report is already available for download from our side. There's been hundreds of downloads already, so clearly it is attracting a lot of attention. Now, I'm going to start the questions with a question from Emily Ong, who I know from Singapore. Emily is asking a very important question in the context of this report. Most non-English speaking countries will find that the MOCA or the MMSE, etc., are not culturally appropriate and sensitive in assessment. Are there support to help these countries in coming out with a better diagnostic tool in terms of research? So the MOCA, for those of you that don't know, is a questionnaire that is administered to a person that feels they have to be diagnosed for a possible Alzheimer, dementia, etc. Many people are saying that these are not culturally appropriate tools. The report does address that, and I would like to pass that question in the first instance to Serge Gauthier. Serge, please.
Thank you very much for the question. Very important point. I touched a bit on that in my short presentation. There is an entire chapter, chapter 6, dedicated to cognitive assessments. We go into remote assessments, but we also go into culturally adapted cognitive tests. I mentioned the VCAT from Singapore as an example of innovative work. The entire scale is actually in the report. So thank you for this question. Indeed, we flagged that as an issue still to work on.
Thank you very much, Serge. Now I have a question from Anita Madison, who is asking how to proceed with a patient that demonstrates anosognosia and refutes the diagnosis. José, you spoke of anosognosia earlier. Could you please address this question?
We have to show a lot of understanding, because if the person doesn't really perceives the symptoms that she's suffering from, we can sometimes make them realize by asking questions and showing to them, demonstrate that they have particular difficulties. And sometimes they come to grips with it. Plus, we need the support of the caregiver, that in certain circumstances, there is agreement, and then we can say that because of these difficulties, they would benefit from treatment. It's my answer to this very difficult question.
It's a very difficult question indeed. And thank you very much, José, for attempting to answer. And telling all the panelists, if any of you would like to add to these answers, please raise your hand. Now, I have a question for Rufus. This is coming from an anonymous attendee, so I don't know who the question is from, but it's very interesting. It says, we do have the same challenges indicated by you, Rufus. What are some of the more practical steps you are taking to overcome some of the challenges, both at national and community level? Sorry, it's from Esther.
Right, thank you very much, Esther, for that very important question. Yes, in Africa, there are pockets of efforts in different countries and across the continent to overcome some of these challenges. Locally, there are efforts, Alzheimer's societies are coming up in different countries and working with people who have interest in dementia care and research, like myself. We're making an effort to promote public awareness about dementia in different parts of Africa. And this is to overcome the problem of stigma and the wrong perceptions about the condition. Then in addition to this, there are also efforts in different centers to introduce multidisciplinary care frameworks, like memory clinics, with multidisciplinary care for patients with dementia. That's another effort. And then on the continent level, for almost 2 decades, Professor Raj Kalaria has organized the Brain Aging and Dementia Conference in Kenya in the last almost 20 years. And this is one of the efforts, to empower African researchers, to generate more evidence that can influence policy and practice on the continent. And of course, more recently, we're also coming up with the African Dementia Consortium, which will be a platform for carers, researchers, and all persons who have interest in dementia in Africa, so that we can come together, join forces to move the science and the cure of dementia forward among the continents. Thank you very much.
Thank you very much, Rufus. Could I ask now, please, Pedro, to take the next question, which is from Neha Sina, and it's focusing on what are the early diagnosis technologies available. There's also a related question from Lilia Mendoza in Mexico about what about young persons with an early diagnosis? Could you try and combine the two, Pedro?
Of course. So there are technologies, as I explained, called biomarkers that are capable to, in certain circumstances, detect the presence of the pathological process that causes the dementia, right? So I think with the use of these techniques, you can find evidence of the presence of Alzheimer's disease, for example. So if a patient presents early symptoms of the disease and has a positive biomarker, we may say that this person carries the Alzheimer's disease pathological process in the brain, and possibly the cause of dementia is due to Alzheimer's disease. For the early cases, I think it's important to use these technologies because there are several other causes that are associated with dementia in young people. So therefore, the use of these biomarkers are important to rule out the presence of Alzheimer's disease as a possible cause of dementia. And this is important because we have symptomatic therapies for Alzheimer's disease that can be indicated in these specific cases.
Thanks so much, Pedro. Complicated to answer such a linked question. Now, I have a question here from Nuha Bengayed in Canada for Roger. Roger, the question is how to make people living with dementia speak out more to advocate for a better quality of care. The cancer survival normally are very vocal. Why, while we do lack strong voices like you, and I agree, it's very difficult. So, Roger, how do you think we should approach trying to recruit more advocates like you?
That's a tough one, and that's a stigma-related question, actually. People living with dementia, this whole culture worldwide, it's a culture of silence, right? And I think that's what motivated me to speak in the first place. It was a stigma-related event that I had, and I happened to say more people should speak openly. So my mentality is if I'm in a schoolyard and a bully is pushing me, well, I've never been known to shy down. I would always push back. So the more I see stigma, the more I push back. But, you know, I do it by example. And what I mean is I'm sitting here speaking to you openly. I speak every opportunity I can get. And I'm hoping that that culture, that, you know, when people understand it's okay to speak openly, it's okay, it's by example. I would encourage people to think about it, have that discussion with stigma and have that conversation. You're giving me bad advice here, stigma. You're you know, and I'm kind of tired of you, stigma. So guess what? I'm parting ways with you. And I think that's how we should all think about it. Have that conversation with stigma, get past it. Because I'll tell you one thing, there's nothing more gratifying seeing the ripple effect from when we do speak.
Roger, thank you very much. You're right, the question is about stigma. A lot of testimonies around that in the 2019 World Alzheimer's Report for inspiration about how to get past the stigma issue and what it means for those that are stigmatized. Roger, once again, thank you for addressing that. My next question is to Claire. Claire, there's a very practical question for you here. How do you integrate the university people, the students, into caring for the people with dementia? Because they have to show interest in the disease. There is a knowledge gap that needs to be addressed, and it's from Gita David-Dorky. Please, Claire.
Mm-hmm. Well, I think what I've begun doing, and I'm very fortunate that McGill has been so open to it, but I'm now giving lectures to the medical students, like personal, you know, we're really teaching from a patient person-centered approach. You know, prior to developing this program, I think that a lot of the lectures that the medical students had been receiving were more about, you know, from the healthcare professionals, the doctors, the various professionals giving the lecture. But, you know, I've managed to convince the university to allow them to have me in the classroom sharing the story about from the moment of diagnosis, what we as a carer goes through and what the most important information that they need to have. So for instance, right now that we know when we were looking at McGill, a lot, or perhaps even other medical universities, they're learning about the disease and they're learning about perhaps the medications, the pharmaceutical approaches that can be used. But, you know, knowing that there is no cure right now for dementia, you know, I'm looking at it more about, you know, what is the prescription that the medical students need to give people? What type of information do they need to give? And including about how the medical students need to understand how to navigate the local public healthcare system, because it's not only about giving them information about the illness, but it's about letting the people know who come to the ER, who come to the hospitals, about, you know, what's available in the resources. So it's you know, McGill has been very open. We're using a multidisciplinary approach. So we're working with various faculties, the School of Physical and Occupational Therapy, School of Social Work, nursing, and family and medicine. So I really think it's about, advocating to your university. If an ordinary citizen like myself can create this program at one of the best medical schools in the world, I think I really encourage people around the world to do the same.
Thank you so much, Claire. A very good amount of advice there. There is, whilst I was looking at the various questions, there are so many. I saw that there is a point in the chat from someone called Girish Padmananan, I think, I cannot read the whole name, who is saying that they are taking care of a parent who has early stage dementia and was hoping that we could provide the video recording of this session because they would love to share it with siblings and relatives. Yes, it will be available on our YouTube channel. Bear in mind, there is a lot of other information also about people with early onset, sometimes with people with early onset speaking about the experience themselves. So I do recommend you to take advantage of that. Don't know which country are you from, but there will be an Alzheimer or Dementia Association in your country, and I'm sure they will have similarly a lot of resources that you can draw on. Now, I've tried to involve all the panelists in some of the questions, but there are just so many that is quite difficult. So I wanted to ask one to Suvarna, who hasn't been involved yet. In countries who don't have access to appropriate resources such as biomarkers, Suvarna, what resources are available for them to assist with the diagnosis of dementia? This is from Calisita Barron.
Today, for the diagnosis of dementia, we don't really need biomarkers for providing service. So I think the lack of biomarkers should not come in the way of making a diagnosis. What we need is a good clinical examination, proper cognitive tests that can pick up deficits early, and also strengths in the cognition that is still there. We will need some blood tests because in middle-income countries, you can have treatable causes of dementia, B12 deficiencies, infections, and then we can do a basic CT scan to pick up vascular dementia that is quite common. MRIs are available, and in people with mild cognitive impairment where you're not sure if they are developing Alzheimer's disease, we can also do a FDG PET, but that is as high as we go. So I would say that a good clinical examination with a CT scan is something that we will still need to make a diagnosis of dementia when you have a lot of treatable causes.
Thank you very much, Suvarna. This is a very nice way of answering this complicated question. And yes, don't be fooled. There isn't yet a biomarker really available. We're talking of something that is going to come soon. But when it comes, also, we don't know yet where it's available. Part of the report is about raising awareness that these things are coming, that there is going to be more demand. Pedro, I think you had your hands raised. Can you?
Yes, it's just to emphasize what was said. The dementia is a clinical diagnosis, right? So we need actually to roll out on this diagnosis process treatable causes of dementia. But this is absolutely correct. The biomarkers serve to identify, to give a name of the disease that is causing dementia.
Thank you very much for clarifying that. Many people are confused about that point. Very good point. I have a really interesting question here, and there is a lot of questions like that in the thread. So this particular question is from Sharon Hall. Why don't we give more focus on related dementia, like frontotemporal, etc., which are not talked about enough, and people are so misdiagnosed? A previous question in the thread said, why is it so difficult to diagnose frontotemporal? I would start asking Serge, but then every panelist is very welcome to come into this one. This is a really big question.
Thank you for the question. Indeed, the report is about dementia, not just Alzheimer. And we made a special effort to go into the other causes. This is in chapter 17, re-evaluation of diagnosis over time. And it addresses many issues, such as you see someone in early stage of dementia, be aware that it could change over time into something different. The natural history is sometimes what determines the final diagnosis. I think José also and Pedro can add to that. Yeah.
So I like to add on what Serge said. The most important thing is that there is a wide range of symptoms, not only amnesia or memory problems. So these individuals, they have behavioral problems, they have difficulties to articulate words, they have difficulties to understand words, and they have difficulties actually to have a fluent speech. So this is one of the points of the report. So the report divides the dementias in typical dementias and atypical dementias. So the typical dementias should be assessed by a specialist, and the specialist has the knowledge to make the proper diagnosis of a frontotemporal dementia, for example. Another important thing is what Claire Webster was saying. So I think one of the roles and one of the plans that we have in the future is to bring actually the knowledge about dementia to medical students and make disseminate the different forms of dementia and the atypical forms of dementia in order to make this diagnostic more simple and to medical doctors.
Thank you very much, Pedro. There is one last question I'd like to answer, I think, in the time that we have. It's coming from Rina Tewari. The impact of COVID-19 pandemic, mainly lockdowns, on the needs of diagnosis. Do you have any insight? The report does go into quite some depth about that. Any of the panelists want to take this question in particular? Okay.
I may, since many of these, those who suffered the most from the lockdown were older people. And for sure, there was an impact in terms of lack of socialization, a change in the routine, which triggered two things mainly: deconditioning, worsening of symptoms associated with the dementia, and some behavior disturbances that made the life of the older person suffering from dementia much more difficult, as well as for the caregiver.
Thank you very much. José, Claire wants to answer, and Roger. Claire first.
Yeah, well, I just wanted to say the impact on the carers has been significant. Many people who are waiting to see a doctor to receive a diagnosis who are not informed at all. Imagine these carers that were, at home alone, not understanding the behaviors, constantly asking, is this normal? Is this normal? Causing a lot of frustration, coping mechanisms that people started using, to cope with their stress, just not knowing where to access resources. And then those people that were really perhaps receiving some type of home care support were afraid to have any type of professional care partners come into their home. So it really had a significant impact on carers.
Thanks so much, Roger.
I just wanted to make a point. You have the pandemic of dementia, then you have a pandemic of COVID, and these two pandemics collided big time. And when it was going into lockdowns in Canada, we may have another one, but we went into a series of lockdowns, and I live alone. And I want to reiterate what José said about the isolation issue, because I'll tell you, I sure felt it. And I have many friends with dementia, and I didn't bring it up, but they were all saying, I said, I don't know about you, but these lockdowns, holy cow, am I struggling? And I heard this comment over and over and over again. So, when you get these two pandemics colliding, it's a hell of a situation to be in. I hope we put this pandemic behind us. Thank you.
Thank you very much, Roger. Such amount of testimonies around the effects of the pandemic on these. Important to acknowledge that. Thanks. This was an important one to ask. Now, it's time for me to start to bring this to the end. I'd like to thank everybody that has asked questions. We haven't answered a lot of questions. There were questions on mindfulness, on risk reduction and prevention. Now, some of these are addressed in other webinars of ADI. There's one on risk reduction and prevention, for example, in fact, two that we did last year. You may want to watch the recordings for that. There's also an interesting strand on public health that would require probably a long time for us to really tackle that in depth. In a way, the whole report is a homage to that, because we actually want to take actions, and for that action to result in awareness raising of a number of issues that are addressed in the report. I'd like to introduce you to our next webinar, because this report is complicated and some of these questions can only be treated in much greater detail in a different area where we don't have such a short amount of time to answer them. So our next one is going to be on the 19th of October, 1 p.m. London time, 8 a.m. New York time, and it's going to focus specifically on a subset of the report, innovations in diagnosis and diagnostics. So we're going to have a series of webinars coming out of this report, because there is just so much in the report, and we acknowledge we need to do more and we need to do better. Now, I think this is the end of the webinar, so I would like to thank you, all of my fellow panelists, all of the team members of ADI that are behind this, all of the contributors to the report, and all of you that have been online, have been following us. I know each one of you have their own stories and journey, and I want to acknowledge that without you, our movement would be nothing. Please continue to make your voice heard, and thank you so much for being with us today. Thank you. We're very happy World Alzheimer's Day.